Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Welcome back to part 2 of our 2-part series on challenging patient interactions, conversations that matter. I am Leanna McGuire, your host for this podcast, and I'm pleased to again welcome Dr. Heidi Moad as our subject matter expert. Dr. Moad is a neurologist and medical writer who has been writing educational materials for healthcare professionals and the public for over 10 years. She's also speaks at professional conferences and works with undergraduate and medical students at Case Western Reserve University. Welcome back, Dr. Moad.
Thank you so much for having me, Leanna.
In the last episode, we covered why challenging patient interactions occur and the different types we may encounter. Now let's discuss other aspects of these interactions. For example, I know we touched a little bit on this in the first episode, but is it possible to maybe not avoid, but at least limit challenging patient interactions? And if so, how?
I don't think it's possible to completely eliminate them. So I think that given the situation that patients are dealing with their own illness or the illness of a family member, it's going to be impossible for patients and healthcare providers not to have challenging interactions because neither patients nor healthcare providers are robots. So everybody has their own emotions, their own way of dealing with things, and it's not always going to be pleasant. So I don't think it's possible to completely avoid them. But I think acknowledging that it's almost inevitable that they're going to happen sometimes is a really big step in potentially managing them and having the best outcome. So there are a couple things to consider. And one of those is that, unpleasant interactions, hostility, potentially blaming, crying, disbelief, noncompliance, all of those kind of things are possible. And really any patient can have these kind of reactions. Any patient might not like their healthcare provider. There's all kinds of reasons. They might not like you because of you remind them of someone that was really mean to them in the past that has absolutely nothing to do with their healthcare at all. So there's all these different kind of things that people bring into this interaction that's not personal. But I think knowing that is really helpful because when you're dealing with a challenging situation and already you know that it's not about you. You are just as a healthcare provider, you are just a blip in the patient's whole entire life. So the fact that it's a challenging interaction and that it's not about you, but that you have to do your job, and your job is to try to get the best outcome for the patient. That's why you became, a nurse or a physical therapist or any kind of technologist or physician or any healthcare provider. It's because you wanted to help patients, right? Or else you wouldn't be doing this. So knowing that challenging interactions and them not liking you or what you have to say is just part of the whole story is a really good way to go into it with a sense of being realistic and a sense of understanding that that's a challenge you're also going to have to learn to deal with so that you don't get shocked or disappointed or surprised or blame yourself every single time.
Really good point. I'm so glad that you said that because I really do think that acknowledging does create preparedness just in the fact that it's going to happen because we get our feelings hurt when patients aren't nice to us or we have bad interactions or, God forbid it escalates. So I love that you brought that up. That's a really, really good point.
Right. Thank you. Yeah. Everybody will get can get their feelings hurt. But if you it's a lot about expectations. If you already know that this is likely to happen, you won't get your feelings hurt. Yet at the same time, that doesn't mean, oh, who cares about this patient? They're just rude. It's not about me. I don't have to address that rudeness. I mean, it's not to that extent. You still have to then try to, help them cope with their feelings, because, as a healthcare provider, again, we're not robots. So if it was a video game, you could just press a couple buttons and make them better, but it's not that way. So helping them requires really addressing a lot of the issues that are going on, not just the diagnosis, the prescription, and you're on your way.
Right. And that kind of opens up another series of questions in a way, because you were saying, we don't necessarily just have to accept that we are going to be treated badly in a sense. Mm-hmm. There are some things that we have to think about. So a couple of things that you said I'd like to pull on. Number one, you talked about patients crying or being non-compliant and those different reactions. Can those things sometimes be cues that interactions could get more complicated or challenging with that individual?
It's possible, but I have to say, not always. So I have taken it that way myself. When I was practicing and someone was, very unpleasant, I would often assume that the next visit was going to be unpleasant, but not necessarily. And especially if you're dealing with an outpatient, but even with an inpatient kind of situation, the next time you see that patient, they may have had time to think about what's going on, to think about their diagnosis, and even to potentially ask questions that are a little more proactive. What does this mean? What do I have to do? Is there anything I can do to make this get better faster? Or is there anything I can do to really minimize the impact this has on my life? I mean, they might not use those words, but that's really what they're asking. And so they're not always going to act the same way, because you're potentially telling them something, or they've just gotten news that they're not happy about. By the next time you see them, even if it's just an hour later, like an inpatient, floor nurse interaction where you're seeing them really frequently, already their attitude about the situation may have changed, and they may be ready to deal with things a little bit differently. And so I don't think they always are going to behave in the same exact way.
Wow, that's important too, because I think as healthcare professionals coming in for a second shift after a bad one with a patient, we can be a little defensive and, have our guard up. So I'm glad that you brought that up as well. If you do have someone that it's just, the conversation or interactions aren't going well, and there is some indication that they aren't crazy about you or, fond of a particular healthcare individual, is it recommended to change assignments in that situation?
It might be. So sometimes it can be, and sometimes that can actually be really helpful. And, a lot of times patients, and I've seen this so many times, and sometimes it just didn't even make sense to me, where someone would like me, but wouldn't like someone else who I actually thought was probably better than me, or the other way around, where they definitely didn't like me and they liked someone else. So sometimes patients may even feel a little bit empowered if they have someone different that they can talk to. Maybe they can even complain about you, get it off their chest, and then move on. And again, it may be because you're associated with something really unpleasant that's happening in their care, or it could be that you remind them of someone or something. Sometimes it is even our fault. I mean, maybe you were really busy and you had to get, maybe you were looking at the clock because you had to do something else at a certain time. At 3:00, you've got to be out of that room and go do something else, that has to be done at that time for another patient. And so they can perceive that and get offended that way too. So sometimes it is kind of our fault in the way we come across. Sometimes maybe you got paged and walked out of the room and they really didn't like that. So there's so many different reasons why the interaction might not be great, and potentially the interaction with someone else might be better for them.
That's a really good point too, is the perception. And I think, sometimes with technology, they could be looking up medical information on their cell phone, and an elderly patient can be very offended by that because they don't know what they're doing. And it just feels like, So you're bringing up some really, really important points. You also mentioned fault there for a second when we were talking about looking at the clock, but are these challenging interactions, is there blame? Is there fault? Or should we let go of that whole scenario of blame?
I think we should really let go of the whole scenario of blame. I mean, I think if a person is having repeatedly negative interactions, more so than other people, then maybe it's time to see if you can get some help. And this can be very difficult for healthcare providers to reach out to. I've heard just minimally about some physicians getting personalized coaching for this kind of thing, but it's really not common. And if there would be any way to get help from, outside your institution, or just somewhere where it wouldn't be perceived that you are to blame, or that there's something wrong with you, maybe you could talk to someone, a therapist or a coach or something, to get an idea if you're repeatedly doing something wrong. So you gave a really obvious kind of example that could potentially, it's a nice example, but if you look at your phone, or if you look at a tablet on patient information, and it annoys people, it would help to just say, I'm looking at your results, or just something like that every time you do it, and to make it a habit. So, if that was potentially a reason that people constantly get mad at you, then you could do that, and you could make it obvious to them that you're not just checking your emails or something that doesn't have to do with them. And so, I'm ordering your medication to come up as soon as possible, or I'm looking at this, just something to show them what you're doing, and that you are actually engaged, even though you're not looking at their face.
Nice. Excellent. Communication, right, is the key. Absolutely.
Yes.
So are there potential problems? We touched just briefly on some of them in the first episode, but potential problems that can occur due to stressful or negative patient interactions? And if so, can you give some examples?
Potential problems for healthcare providers, you mean? Or
in the aftermath of.
I mean, in the aftermath, definitely there are. And a lot of times we're not necessarily aware of how we are responding. So sometimes a healthcare provider, because, we all have these reactions, and sometimes we maybe try to bury them or deny that they're happening, is you may try to avoid too much interaction with other patients who remind you of someone who was extremely hostile to you. And that could be unfair to those patients, because we know that not everybody who looks the same or has the same diagnosis is going to act the same way. But of course, we all can sort of get that sort of reflex reaction that could be a little bit unfair. But if we don't think about what happened and sort of explore why it happened, we can end up inadvertently or on purpose avoiding certain kind of patients. And that's one thing. Some people may get so burned out that work becomes very stressful. I mean, you can get headaches before you go to work. You can get neck pain. You can get all these different kind of things because you're tensing up and you're so worried about what's going to happen next. Potentially blaming is another thing that can happen, blaming other healthcare providers. So if you start to feel attacked and you start to feel like everybody's blaming you, or even just one person has blamed you very aggressively, you can start, lashing out at others to try to not make it all about you. And so there's a lot of really negative consequences that can come, and side effects almost that can spread, that aren't necessarily even directly related to that challenging interaction, but it takes its toll.
Sure. I know you mentioned counseling or seeing a therapist when you're talking about when we were talking about the blame issue, but would you recommend that as a post, I don't want to diagnose, but I was going to say post-traumatic, but if you've had one of these interactions that you really feel has affected you, would you recommend that as having, speaking to someone?
So, based on what I've read, and what I've read is mainly research about this, so it may be a little biased. It seems that people do. But of course, when you're looking at research articles, there's going to be more of the type of participants or study subjects who have sought out some kind of therapy. So from what I understand, it seems to be common enough that if it does happen, you certainly should consider it. I haven't seen that there's any adverse effects of getting therapy.
Sure.
It seems that probably the most negative effect is maybe denying that there was a problem. And I think that's one of the things I've seen in some of the research I've read too, is that a lot of people try to just kind of bury it, go back to work the next day, move on, say that was a fluky, weird thing, which it probably was, and it probably won't happen again. But not dealing with it or not dealing with the feelings can result in behaviors that are not helpful professionally or physically or, with other people and with other patients.
Sure. And, when we talk about professional therapy, but there are a myriad of EAP in most positions, hospital anyway, maybe not community, but most employers have some form of EAP that would be worth investigating.
I think so.
Yeah. So that would be something that I probably could be helpful. Okay. Now, how do we as healthcare professionals reframe our own feelings about these interactions? We've talked about a few things, but.
Yeah. Well, I think one thing is to incorporate it into the education of healthcare professionals, both the initial education as well as the continuing education, because I think the more healthcare professionals of every type acknowledge that this is real, the less it will be a surprise, and the more people will not feel personally attacked or have their feelings hurt if they're dealt with hostility. So that's really that's an important feature. And then also supporting each other. I think, we talked in the last episode a little bit about the violence that can occur against healthcare providers from patients. And I think, if you have a bad feeling, to ask for help. And if someone's asking you for help, it can be really hard. I know everybody's super, super busy, but to accompany them with that patient, or maybe to divide your students and have a few go in there. Sometimes it's not, just having numbers of people can be preventative. And another thing is, if you have a bad feeling about someone and you see someone else could potentially be exposed, warn them or see if there's anything you can do to help protect them. So I think really looking out for each other and not being afraid to ask for help can be really beneficial.
Yes. And being supportive of each other eliminates being afraid to ask someone for help. So
yes,
it's huge
definitely.
that we do that. Yeah. Huge that we do that. I'm glad you brought that up as well. So let's talk solutions. Are there any?
Well, so a lot of the things that I have been able to find lately is that there are continuing education training that occurs in services and CMEs and lectures and training and all kinds of things and groups. And I think that taking the time to do that kind of training once in a while can be really helpful. So you had mentioned kind of something that I would have never intuitively thought of, which is that having your stethoscope around your neck was actually harmful to you at one point, and you were very fortunate that it didn't end up with anything bad. But, that's not something that is intuitive for anybody who is not thinking about perpetuating violence themselves. I wouldn't think of that. So most people wouldn't think of that. But so going to continuing education about wellness for the healthcare provider is really important. And sometimes it can be a continuing education that's directed towards your specific area. So for instance, people who work in the emergency room may have different concerns that people who work in a pediatrics ward, because, you're dealing with a different type of population. So in a pediatric situation, it could be the parents could get very hostile, whereas in the emergency room, it's, whoever happens to come in, but there's also some benefit there that there's a crowd of many people and, not as closed off. And it could also be very different in a pre-surgical room or some place where people have anesthesia. So I think specialty specific can also be good once in a while. It doesn't have to be the only thing you do, but sometimes.
Right. Good. Excellent. So I know that there was a time I worked with a couple of individuals who all got together and took self-defense classes, but is that something that actually is beneficial, or do we set ourselves up for some version of liability at some point with that approach?
So from what I've seen, this doesn't seem to be a common approach. That's not to say that it's not beneficial, but I don't think there's evidence to prove that this is overarching the right solution. Now, do you set yourself up for liability? I don't know that I can speak to that. That's a great question. I think for a nurse or any other healthcare provider to actually employ physical self-defense, I imagine the situation would have to be so significant that I don't know. It could potentially be a setup for liability, but I imagine the backstory would be pretty significant. It's probably not a bad idea to have some basic concepts of how to protect yourself. Doesn't necessarily mean you have to be a martial arts expert, but some ideas of how to protect yourself. And this could be more in terms of, an emergency call button or some other way to potentially get help or lock a door or unlock a door, or just something to protect yourself within the environment that you're in. And that could be potentially part of an onboarding or an education for healthcare providers in a particular location. And again, that may also be specific to the type of patients that are being taken care of and what their physical abilities are.
Sure. Right. And we are talking defense and not offense. So we are, that's important to clarify. And the other piece is that, not all interactions go to that level. We mention them, we talk about them, but a lot of these challenging interactions are verbal and it doesn't escalate to that point. Just to clarify where we're going with that. So that's really helpful. And we talked about counseling. We mentioned communication and the importance of it. Communication is the key. And we've also talked about how it's not just nurses who are vulnerable to these interactions. It's every discipline across the board. We have, like you said, physical therapists, respiratory therapists, physicians. It could be just about anyone that has that is in that arena, so to speak, and ends up having that challenging interaction. Can we talk a little bit more? I know in the first episode, we talked about the importance of that interdisciplinary communication or interprofessional communication and the importance of it. What kinds of things should a nurse be informing a physician of if they are having these interactions? Is it helpful to make the whole team aware? What's the best case scenario for that communication piece?
I think it's a good idea for everyone to be on board and understanding, that the patient is having a hard time dealing with their diagnosis, or the patient is not happy with this hospital care, or the patient hates the food, or just, it doesn't have to be a big central part of it, but I think it helps everybody. And it helps people to acknowledge that, even if it was something as upsetting to the patient as hating the food. But of course, that's not, fatal, but it would be something that anybody, who's taking care of them might benefit from knowing, because they might say, I know this diet that you have to follow is really tough. And these are maybe some of the ways that people have dealt with it. So it doesn't have to be the most central part of the conversation if it's not the biggest aspect of their care. But some acknowledgement, I think, can make patients feel a lot better. And even if they've expressed it to one person and then another person knows about it, that can actually make the patient feel really cared for, because they know you care enough that you remembered what they said, and you're not only thinking about the absolute most important critical things, putting that IV in and getting that medication in and, measuring their oxygen level, you're also thinking about their comfort and expressing it to someone else. And then that other person is talking about it. And so it just shows them that you care enough to listen, that you were listening, and that you talked about it. The other person is talking about it. And it just, they might not say, oh, wow, I'm so happy that you guys are all so nice, but they won't be as mad, probably.
Right, right.
I think we would all feel a little bit happier knowing that someone is acknowledging our concerns.
Wow, the power of empathy, right?
Yeah.
It can be disarming. And I think that's a really huge takeaway from this conversation. So I appreciate that. What about involving family? If there's a difficult interaction, is that helpful?
It can be. So sometimes it can be worse. Sometimes family like to kind of stick together and feel like they're a team. And some family members, particularly if they actually don't get along very well, this is their way of showing their family member that they care. Is, I also don't like that. So it's all of us against them. So it might be helpful, but there might be other situations or other kind of complications behind the scenes that you don't know about. And so some people feel like they have to show that they're being protective as a way to show their family member that they care. And sometimes it can be helpful. So sometimes a family member can understand what you're saying in a way that's a little bit more objective, or it just see it from a different angle and can help. So it's always a good idea to try. No, that's, I think.
It's okay, good. Yeah, that's a really excellent point. You're absolutely right. We've certainly seen that with family members. Maybe for the purposes of deciding or figuring out whether this person's behavior is their normal baseline, or if there may be cues, as we spoke about earlier, that they're struggling with other things and it's coming across in a different way. So that's really, really helpful. This conversation is so important, and I'm glad that you brought it up. We all deal with it. It's important that we go over all of these details. You've given us some great takeaways. The conversation has been fantastic. Any concluding thoughts that you want to leave us with, or anything that you want to emphasize before we conclude the podcast series?
Yeah, sure. I think just for healthcare providers, it's important to recognize that you're gonna have challenging patient interactions, and that it's a constant learning process. I think we can all learn, even the day before you retire, some new things about how to manage all of this. And so just to never blame yourself for not doing it perfect the first time.
Fantastic. Yeah, that acknowledging piece boy, am I glad you brought that up. That was fantastic. All right. Thank you so much. Now, during this second and final episode of our series, Challenging Patient Interactions and Conversations That Matter, we've talked about why challenging patient interactions occur, along with different types, how to potentially avoid them. We talked about the blame game, problems that can occur from these discussions, our own feelings, and again, possible solutions. So extremely valuable information that we can all take into our practice to make us better clinicians. Thank you so much again, Dr. Moad, for joining us and sharing your expertise. We really appreciate your time.
Thank you so much for having me. It's been delightful talking to you.
Great. Thank you. Likewise. And thank you for listening. And be sure to check out our list of other informative podcasts and courses on elitelearning.com as you grow in your career. This is Leanna McGuire for Elite Learning by Colibri Healthcare.
This podcast featured content from an accredited CE activity provided by Colibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.